Very good morning. Dr. Nipun will be very interesting topic. All right. Yeah. So, पूछूंगा तब recording is still हाँ हाँ. So good morning everyone. So regarding the pachychoroid spectrum, one mic on. This on. So spectrum as Dr. Suresh sir mentioned regarding the CSCR. Econ? Sorry, the slide kind of. So, what are the components of pachychoroid? Pachychoroid generally means the in the choroid the pachyvessels. Pachyvessels means the halar layer is dilated. We have two layer of blood vessels in the choroid, in the halar and the satellar layer. Uh, Dr. Shiv? Oh, optical. Halar and the satellar layer. So when the vessels are patchy vessels, that means the permeability of the vessels increases. When the permeability of the vessels increases, it compresses the choriocapillaries and the RPE. So when it compresses the choriocapillaries, there is thinning of the choriocapillaries and the satellar layer, which causes the ischemia and the accumulation of the subretinal fluid. So this is the schematic diagram of the choriocapillaries and the pachyvessels. One second. So regarding the pachyvessels, yes. हाँ हाँ मेरे वाले से। अब है। Sorry for the interruption. Yeah. So we have the uh, आपका माइक ऑन है? No, it is off only. No, it is off only. No, sir, no problem. Now it is fine. So with the sorry for the interruption. So we were at the Pachyvessels. So what is Pachyvessels is the halar vessels get dilated. So when the halar vessels get dilated, it compresses the satellar layer and the choriocapillaries, which causes the accumulation of the subretinal fluid below the RP, which causes our most common central serous chorioretinopathy, and it causes the choroidal ischemia, which leads to the formation of wedges because of the ischemia. There is increased production of the wedges and which causes in further pachychoroid neovasculopathy. So what happens in the pachychoroids, the most important point to remember is that all the pachyvessels are hyperpermeable, but all pachyvessels are not hyperpermeable. So when we talk about pachychoroid, it is not only the thickened choroid, it is the increased permeability of the pachyvessels. But the Pachyvessels means the dilated Pachyvessels. All vessels are not hyperpermeable, and predominantly we see the pachychoroid spectrum in the thickened choroid. That is, the subfoveal choroidal thickness is more than 400 micron meter. In some studies, it is given as 350 micron meter. But all said and done, Girdhar et al. And had studied 20% of the patients with leptochoroid, that in the thinner choroid, also had polypoidal choroidal vasculopathy. So pachychoroid is a continuing spectrum. So what happens is what causes pachychoroid? There was an old concept of CSR which said that then isolated localized defect of the retinal pigment epithelium causes the CSR. Now the newer concept is related to the not to the retina, to the choroidal venous congestion. We have the vortex veins. Okay. So what happens? There is the thickened sclera. It's not given in the diagram. We have the suppose the hypermetropic eyes, we see the CSR more common. Why? Because the thickened sclera is uh, predominantly the main risk factor. So the thickened sclera have the scoloids as the particles. So when the sclera is thickened, it compresses your vortex veins. Okay, so when the vortex veins is compresses, the vortex vein has a watershed zone with the choroid. Vortex veins has the watershed zone uh, with the choroid. So when it causes the compression of the vortex veins and it causes the venous overload choroidopathy. So the blood flow in the veins increases. So the vortex venous overload choroidopathy, Dr. Spade has developed a new concept which is called as the vortex venous overload choroidopathy, which causes the your pachychoroid spectrum. So it further compresses the vortex through the vortex venous overload choroidopathy. It compresses your the pachyvessels forms. Then the pachyvessels compresses your choriocapillaries and the Sattler's layer. So this is the pathophysiology. This is the normal choroid. So what I was talking about is the venous congestion, remodeling and stasis of the vortex veins. Then it causes the Hallard-led dilatation. Then it compresses because of the increased hydrostatic pressure. It compresses the choriocapillaries and the Sattler's layers, and it causes the ischemia also, which leads to new vascularization. So these are all the pathophysiology of the pachychoroid. Now, what happens? It is a continuing spectrum. So because of this pathophysiology, so it causes this. These are many diseases. First is the pachychoroid pigment epitheliopathy. So, this is the spectrum pachychoroid pigment epitheliopathy. So I want to ask Dr. Sudhanshu regarding the spectrum. So first, what happens is the pachychoroid pigment epitheliopathy. So we have seen many OCT changes, OCT cases in our day-to-day OPD with pachychoroid pigment epitheliopathy. So can you enumerate the difference between the pachychoroid pigment epitheliopathy and whether it is progressing to CSR just based on the spectral domain OCT? How can we find out whether this is the just a pachychoroid PPE or a central serous chorioretinopathy? Because our management then changes. Okay. Yes. So pachychoroid pigment epitheliopathy is just has a hyperreflective RPE. So it will not. It is just a. It is called as a forme fruste of the central serous chorioretinopathy. Forme fruste means just the starting, just the initiation point of the central serous chorioretinopathy. The RPE has started to change because of the compression, because of the overload compression of the Sattler's layer. The RP has started to change. The RP pigment has epitheliopathy changes have started to come. So we will see only the hyperreflectivity on the PP. In further slides, I will show you the OCT picture also. Now, then comes the continuum. When the fluid accumulates, it will come to the central serous chorioretinopathy. So when there is ischemia, the VEGF will form. Then it causes the pachychoroid neovasculopathy, and when it further progresses, it causes the pachychoroid choroidal vasculopathy. And when it is near to the disc, there is another spectrum called as peripapillary pachychoroid syndrome. And there are two more things I could not include in this slide, but there are two more entities. Can anyone enumerate? Dr. Shreya, Dr. Himanshi. There are two more things in the pachychoroid spectrum. CSR is there. Yes. So there is two more things called as focal choroidal excavation, and one more is a newer entity described last year only, that is pachychoroid vitelliform maculopathy. Okay, so we see the best disease, the vitelliform material. It's all described in this. So the pachychoroid pigment epitheliopathy. So if you see, very small RP detachments have started. As Dr. Sudhanshu sir has mentioned, the fluid beneath the RP, the small RP bumps, and we see day to day in our OPD, these RP bumps, hyperreflective foci just has started. It is just the beginning form fruste of the central serous chorioretinopathy. Now, so when the this thing subretinal fluid accumulates in the CSR, it causes the subretinal fluid to accumulate, which is caused the acute central serous chorioretinopathy. So if a patient comes in a day-to-day OPD, that within 4 to 5 days, I'm seeing a black spot within my left eye, and the vision is around 6 by 12. Anterior segment is quiet, lens is clear, optic nerve is normal. We see a halo of fluid, subretinal fluid, uh, at the around the macula. So, what should be our management plan? How do we counsel the patient? Basically, the to modify the risk factors. So what four risk factors, basic risk factors, we should ask for? Dr. Himanshi. Okay. Mm-hmm. 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 Right. So remember the yes.
Yeah, that's very important question. Like, many times the patient is taking some Ayurvedic drops or Ayurvedic drugs, and the steroids are mixed those drugs. Like some people are taking some Ayurvedic treatment for rheumatoid arthritis or some modality. They don't, disclose, but steroid is mixed in those drugs. So we should carefully ask the patient whether you are taking, any treatment, any sort of treatment, Ayurvedic. And then, secondly, sometimes they apply the cream and some local treatment to the also we could carefully evaluate. So, in addition to the known risk steroid risk factor, there are some branches of Ayurveda and traditional healing where they use the steroids without labeling on the bottle. So
Right.
that's important.
Right.
I have seen few cases where people are taking Ayurvedic medicines and we were not like aware that this can lead to IDGs. Yes, sir. Thank you. So
Welcome,
we
sir.
have Dr. with us and Dr. Gupta sir will also share his experience about Vikas. Sir, what is the patient?
Yes, sir. Yes, sir. So clinically very important pulse given by Dr. H.K. Gupta sir. There can be hypermetrophic shift, metamorphopsia. So we give a Amsler grid monitoring also for the CSR patients. So echo jet. The Amsler grid monitoring also and hypermetropic shift and our slit lamp 90D biomicroscopy should be very accurate because sometimes there can be a variety of CSR. There's a fibrin associated CSR, and we have come across the pictures where chronic CSR and posterior scleritis they almost look the same on OCT also. So we need to differentiate between the two because the treatment protocol is different. And multifocal CSR, fibrin CSR, these are the various varieties. So basically, in acute CSR, we need to modify the risk factors. So what are the four risk factors? I remembered it as four S's: the sleep, stress, steroids. So these the yeah, and smoking. So sleep, the sometimes the patients have night duties. The due to the stress, they have insomnia. So these patients are prone to develop CSR. Stress, type A personality patients have more prone to have CSR. Even the H. pylori is also implicated in the CSR. The gastric ulcer, the gastritis patients also have prone to CSR. Patients with chronic tobacco chewer and chronic smoking, chronic alcohol intake is also implicated in the CSR etiology. Long-term use of any medications, even anti-allergics, steroids for skin cream, any route, topical, even inhalational route for asthma, they can cause CSR. So modification of the risk factors. But some patients they want to get rid of the CSR very early. Suppose the patient is a pilot, they have a demanding work. So what you do, we can always do an fundus fluorescein angiography. So there are three main characteristics pattern on acute CSR we see. That is the ink blot leak. Suppose there is a fountain pen and like you have pressed that pen on the blotting paper and that blots. That's a characteristics ink blot leak. There is a smokestack appearance, like from a chimney, the smoke is coming out, and there's a diffuse leak pattern. So when the leak is extrafoveal, we can always do a focal laser to that leak. And but when the leak is foveal, we can just observe. So coming to the further spectrum, when it causes the ischemia, it causes the pachychoroidal neovasculopathy, and we can always seen in the OCT, and then the formation of the pachychoroidal polypoidal choroidal vasculopathy. There is a, very good paper I am always discussing in the OPD regarding the OCT-based diagnosis of the polypoidal choroidal vasculopathy. So I want to ask Dr. Shreya for the polypoidal choroidal vasculopathy, as it is a choroidal pathology, what is the gold standard for the diagnosis of polypoidal choroidal vasculopathy? And if that modality is not available, how can we diagnose it on the OCT? Yes, yes. No, no problem. So nice. So there are thumb-shaped PEDs and there's complex and multilobular PEDs are there. So when you get a small, large PED, thumb-shaped PED or an M-shaped with a notched PED, then probably it is the polypoidal choroidal vasculopathy. So the ICG was the gold standard for diagnosing of polypoidal choroidal vasculopathy. So we had those choroidal hyperpermeability in the mid and the late phases, and there was a branching vascular network. Now it is called as branching neovascular network, and it corresponded to the thumb-shaped PED and complex or multilobular PED. And so the polyps are very prone to bleed. We have cases of sudden diminution of vision due to the bleeding of the polyps in the submacular area, submacular hemorrhage causing sudden diminution of vision. And the third was the sub-RP ring-like lesion, which has the OCT-based diagnostic criteria. So whenever ICG is not available, these four diagnostic criteria is very good. And the last but not the least, there is a shallow irregular RP elevation. So what happens on OCT? RP and the Brooks membrane, they separate. It is called as a double layer sign with a hyperreflective material in between. It is also called as SIRE, SIRE, shallow irregular RP elevation. Yes, sir.
Yeah, Dr. Nipun, very interesting point. It's very interesting for us.
Yes, sir.
So in the clinical scenario,
Yes, sir.
is there any pattern which we see most commonly, or we can
Yes, sir.
see, out of which three pattern,
Yes, sir.
is there any pattern which we see most commonly, or
Yes.
we can see all these three patterns also in one case?
Yes, sir. No, we have seen this PED pattern very frequently, sir. So, some shape PED. Yes, sir. Yeah, yes, sir. This pattern we have seen very frequently. This tall thumbshaped PED and the multilobular PED. We have two, three patients we have injected also, and like they are doing it. They are doing very well with the three loading doses also, sir.
And do you know, out of the anti-VEGF
Yes,
available,
sir. Yes, sir.
yeah, are there any studies there available which reveal that which type of anti-VEGF is the best for CSR? Is there any study available?
Yes, sir. Yes, sir.
Like ILIA?
That's a very valid point, sir, because what used to happen, sir, that studies before indicated that that is a very good question in the sense that before the studies were PDT, photodynamic therapy, plus ILIA was superior, is superior to ILIA. Also, it holds true still also, but now with the advent of newer anti-VEGF such as brolucizumab, faricimab, and this thing, Eylea HD, 8 milligram. They are telling that because of these drugs, because this thing, anti-VEGF monotherapy is also superior to, is comparable to, they are non-inferior to PDT plus Eylea. Okay. So with the newer, because PDT, because of the vertiporfin dye is not available everywhere. So the PDT is not available everywhere. So these monotherapies also has a role. The higher, because brolucizumab, due to the high osmolarity, they are said to have a higher drying effect on the polyps, on the fluid, on the this thing. So it works well. And aflibercept also works well with the 3 monthly dosing regimens. And the Eylea HD and the faricimab, they are coming up. So they are also said to cause a greater regression of the polyp. So there are two things: the polyp inactivation and the polyp regression. Okay. So now there's another end of the spectrum is the uveal effusion syndrome. So as you know, in the hypermetropic eyes, as Dr. S.K. Gupta sir mentioned regarding the hypermetropic. So when the eye is suppose the axial length of the eye is small, so the hypermetropic or the we see in the mostly in the nanophthalmic eyes, there is a thickened sclera. So what happens when the sclera is thick? It compresses on your vortex veins. So when the vortex vein compresses, the watershed zone, because vortex vein and the choroid, they have a vortex venous overload choroidopathy. That is the Dr. Spade theory. And venous overload choroidopathy, because of the venous congestion, the back pressure, the Pachyvessels happen, and this uveal effusion syndrome also happens. This is the mechanism of the scleral resistance, and more research is going on this. So there are two types of uveal effusion syndrome, and one is the non-ophthalmic eyes, and one is the non non-ophthalmic eyes. So non-ophthalmic eyes, due to the short axial length, it causes the uveal effusion syndrome, and associated is a secondary angle closure glaucoma. In non-ophthalmic eyes, due to the systemic disorders, it is an acquired condition due to polyarthritis nodosa, psoriasis, rheumatoid arthritis. There are dilated episcleral vessels, which leads to this uveal effusion syndrome. There is only one entity, this uveal effusion syndrome, in which surgery is indicated in this pachychoroid spectrum. What they do is they do a scleral resection with a, patch graft. So in this, so that the our fluid overload is little decompensated. The pressure is down. So basically, now the pathophysiology, it resides in the choroid. Earlier, it used to be at the we used to find the leak at the retina. So now to treat the pachychoroid spectrum, we should start the looking at the root cause at the choroid. So now, yes, yes.
The state is described is very sometimes.
Very nicely elaborated by sir regarding the complications in which can happen in the non-ophthalmic and hypermetropic eye. So I have a quiz for the fellows. So there's a middle-aged patient which walks into your clinic with mild metamorphopsia. Visual acuity is 6/9. Fundus almost looks normal, and then he has metamorphopsia. Then you switch to do an optical coherence tomography. The choroidal thickness is 480 micron, and there's a shallow pocket of subretinal fluid. Halar vessels are dilated on the ADI OCT, and which is pushing the RP upward. And you have an ICGA which shows choroidal hyperpermeability. So I want to ask Dr. Sudhanshu sir. So the first question is, what is this entity, and where does it sit on the pachychoroid spectrum? So what is this entity? So I have a OCT picture, but it is with the answer. So, yeah. Hmm. Yeah, yeah. No, the OCT is showing a shallow pocket of subretinal fluid between the RP and the neuro inner retina. Huh? Sorry?
Yes.
Yeah, Pachychoroid, but it's mostly a CSR because the fluid is already there. So it is a CSCR. So yeah, answer is CSCR. And so, sorry. So answer is the CSCR. So the as we discussed, it's type A personality, steroids, and stress, and it has a smokestack or in-plot appearance on the fundus fluorescein angiography. So modify the risk factors. So what we do is we modify the risk factors and call the patient after a month to see the resolution of the CSCR. So this is the so it sits on there's a normal choroid, there's the pachychoroid pigment epitheliopathy. It sits on the central serous chorioretinopathy. So how will we counsel the patient? We should reassure the patient, take your sleep well. If you have night duties, then you can change your night duties. You can convince the employer to change the night duties. And this thing, no smoking should be there and avoid stresses. Also, you can give an alprazolam tablet for 2 weeks, and this thing we are giving dorzolamide as it is a carbonic anhydrase inhibitors which acts on the RP pump. So the RP dysfunction which happens if the some CSR cases the fluid has reduced in chronic CSR. One mineralocorticoid antagonist. There's a study also on that. It is being used and the results are good. So Dr. Shreya, can you name that mineralocorticoid antagonist which is used in chronic CSR? No, no, it's a diuretic. No, no. Huh? Spironolactone was earlier used. Now another one is used. Dr. Himanshi? It's an eplerenone which is used, but before using eplerenone, do a serum sodium and potassium because it is a potassium sparing diuretic.
So, Dr. Nipun very nicely elaborated about this sleep and PHR. So, we have to expect that obstructive sleep apnea is right. When it comes to the PSI, specifically recurrent CSR, we are always standing for sleep. If you ask him, it can be given by sleep apnea is associated with CSR and repeated CSR can be linked to the like less yeah, that will not go.
Yes, a very nice point regarding the obstructive sleep apnea, and we should keep in mind. And that regarding pachychoroid pigment epitheliopathy, as Sudhanshu sir mentioned, there was a irregular RP changes with a hyperreflective RP bump, small RP detachment less than 100 micron meters. So another quiz. The 68-year-old Asian woman has recurrent hemorrhagic PEDs and subretinal hemorrhage. OCT it shows a notched PET with a branching vascular network and polypoidal dilatations at the edge. Choroid is thick. The presentation is best classified as this is an easy one. The answer is given in the question itself. Classic type 1 CNV of AMD, polypoidal choroidal vasculopathy, retinal artery macroaneurysm, or idiopathic PCV without pachychoroid. Anyone would like to attempt? Dr. Imanchi. So if you're Dr. Himanshi is going for B, anyone else going for any other option? Dr. Priya, Dr. Sudhanshu, do you agree with Dr. Himanshi? B, okay. You are right, Dr. B. So it is a polypoidal choroidal vasculopathy. So always remember, I in the OPD also, I on the OCT we have thumb-shaped PED. If there is a such kind of picture, subretinal hemorrhage, most likely it is a polyp, which is a tendency to bleed. So what we do see such type of hemorrhage, it is more than 4 days diameter. We give free loading dose of anti-VEGF, preferably aflibercept, And if it does not resolve, then we take up the patient for a surgery. So uh, uh, because the more the time the blood is there, it causes the harm to the photoreceptor. It causes the photoreceptor ischemia. So, three injections. 1 month. 1 month. One. Yeah, if it like that's a good question. But after first month, if it is not regressing, then you take up the patient early for surgery. Yeah. So what I do is after one injection, I call the patient for a close follow-up after 15 days to see the status, how much it is regressing. If it is not regressing, then we can go in early for surgery because we should not wait for the, the photoreceptors to have an ischemia over there. So, and the sub RP ring-like lesion, tall PED, and the double layer sign. These four signs are very important for this thing. So, pachychoroid neovasculopathy. So, what is the difference between pachychoroid neovasculopathy and our classic CNVM and type 1 CNVM is, see, the management is the same. Anti-VEGF is the first line of treatment. But the pachychoroid is with a thicker choroid, and pachychoroid neovasculopathy will require a slightly stronger anti-VEGF as compared to a wet age-related macular degeneration. And the wet age-related macular degeneration will have a thinner choroid. And pachychoroid neovasculopathy will have a younger patients mostly, and wet age-related macular degeneration will have a uh, older age group patients. And there is one entity which is called as focal choroidal excavation. This focal choroidal excavation, it is described due to the because of the this thing RP bowing and the RP sorry. So before coming to the focal choroidal excavation, there is one focal choroidal excavation because of the RP bowing and the sagging of the Brooks membrane. There is an elevation of there is a depression because of the outpouching of the RP and the Brooks membrane. And there are two types, the conforming and the non-conforming focal choroidal excavation. And they also, because of the pachychoroid, they secrete the fluid. There is also a fluid uh, below the RP and the Brooks membrane. So it is the type of a pachychoroid spectrum, and the treatment is their mainstay of the management is anti-VEGF. And we have seen cases with peripapillary pachychoroid syndrome. That means to the nasal to the disc and even temporal to the disc, between the disc and the macula, just peripapillary, there is a thickened choroid and there is a fluid. So we should always treat those patients. So what we do is we do a raster OCT scan on the adjacent to the disc to see the amount of the fluid, the amount of the CME, how much is the fluid, and it sometimes and we should treat those patients as well so that it does not progress further to the macula, and we should treat it with your mainstay of management is the anti-VEGF. So these entities are also being described. And one more entity is described is the pachychoroid vitelliform maculopathy, which we see the vitelliform material. So we had one patient who had bilateral 6/9 vision, and he was given injection elsewhere, but the OCT picture and the vision was the same bilaterally. Then we investigated further and we sent for an EOG, electrooculogram, that is the Arden index. And then we saw that the Arden index was, that ratio was elevated. And the elevated, and they came to know the diagnosis was the best disease. So actually, it was a vitelliform material which was there, which was being misdiagnosed as chronic CSCR. So bilateral recurrent chronic CSCR not responding to anti-VEGF, some material is there, vitelliform material, which is being very similar to your our type 1 CNVM material, type 1 CNVM. So always think of vitelliform maculopathy. And we had one 8-year-old patient with a best macular dystrophy with a complicated with a choroidal neovascular membrane. So we had given intravitreal anti-VEGF to that patient, which responded very well. Three loading doses we have given. So always keep in mind pachychoroid vitelliform maculopathy as a component of the pachychoroid uh, spectrum. So why does the choroid become pachy? As we discussed, the venous congestion, which forms the pachyvessels. Then there is an ischemia plus leak. Due to the ischemia, we have a secondary neovascularization, which causes the pachychoroid neovasculopathy, and further pachychoroid neovasculopathy causes the type 1 aneurysmal dilatation of the choroidal, small dilatation, which is called the PCV, which are very prone to bleed. So, multimodal imaging is very essential for the diagnosis. So, we had one case because we did an OCT. There was a subretinal fluid, but then we looked at the choroidal the thickness. There was a choroid was pushing the RP from the behind due to the posterior scleritis. The choroid was thickened, like the choroid was pushing the RPE from behind. And then there is one more. So posterior scleritis has to keep in mind the differential diagnosis. One more differential diagnosis have to be kept in mind. Hyperemic disc, multifocal CSR kind of subretinal fluid accumulations. That is the VKH syndrome. When we do an OCT, there is a multiple bilateral subretinal fluid accumulation. But the catch is that there will be a fibrin septae in between. So why we should differentiate between the team? Because in one case we should avoid steroids. In another case, VK syndrome, the treatment is steroids. So we should keep in mind this differential diagnosis also. So the management is acute CSR is the observation and modify the lifestyle. The anti-VEGF is the mainstay of management. The epinephrine we were talking about uh, regarding the chronic CSR. Rarely the surgery is very rare only in those non-ophthalmic eyes with uveal effusion syndrome. So acute and chronic CSR, one more point I would like to mention now, there is a classification because some people say acute CSR for 3 months. Then some people say for 6 months. Some people say for consultants say for 4 months. Now there is a separate classification which is universally accepted that it is a multimodal imaging based classification. It is a separate table. So I would share it on the group. So now the final quiz, which statement is true about the spectrum? All the answer is there only. All eyes with thick choroid will develop CNVM. PCV never occur in eyes without pachychoroid features. EDI, OCT, and ICG are complementary and often decisive. And anti-VEGF alone is always superior to PDT in PCV. So all eyes with thick choroid will develop CNVM. That is not the case. All eyes with thick choroid can have pachyvessels, but all pachyvessels are not hyperpermeable. Some are hyperpermeable. PCV never occur in eyes with pachychoroid feature. We have seen pachychoroid, the PCV will occur predominantly, but in around 20% of the cases, PCV also happens in leptochoroid, the thinner choroid. Mostly in females, that paper has seen uh, with a thinner choroid, the PCV has happened. OCT and ICG are complementary and often decisive. And what we are seeing is the OCT based, non-ICGA based diagnostic criteria, diagnosis on OCT regarding pachychoroid spectrum and PCV. And anti-VEGF alone is always superior to PDT. It's not always the case, but although the newer anti-VEGFs they are coming, the studies are going on because PDT is not available because of the high osmolarity of those anti-VEGF. They have a superior more drying effect to the uh, for the pachychoroid spectrum. So the take-home messages, think choroid first. First, we used to think the leak is at the level of the retina, but now we are now going below the retina. We are going thinking of the choroid first. We are measuring, even the softwares are coming up to measure the choroidal vascularity index. It is a one spectrum, but it has many phases such as pachychoroid pigment epitheliopathies, leading to CSR, then to the neovasculopathy, then PCV. Then we have focal choroidal excavation, peripapillary pachychoroid syndrome. Then a newer one is the vitelliform maculopathy. Multimodal imaging should be done. One more important point, geography also matters. This polyfocal choroidal vasculopathy is predominantly in Asian. Central serous chorioretinopathy is in the mostly in the Western countries. And address the choroidal congestion and the secondary neovascularization as soon as possible. That is very important. So thank you. I hope you learned some few pearls of management regarding the pachychoroid spectrum, and any questions are most welcome.
Thank you very much. And many new tools are coming up. More AP are doing more and more imaging models. Uh,
We have Dr. I think Dr. Zeba with us. Dr. Zeba, you have online. Dr. Zeba was our previous fellow. Are you there, Dr. Zeba? No, she's unmuted, so no problem. Yeah.
So we this is you know
Hello, sir.
She's there.
and
Yeah. Sorry.
so
Yeah. A long time, Dr. Zeba. Good morning. How are you?
Good morning, sir. How are you?
Yeah, yeah.
I'm
So,
fine.
how was the how was the presentation? You have any questions or points to add to the pachychoroid spectrum?
Presentation is very excellent, sir.
Yeah, yeah, yeah. So, any cases you have come across or any important points you would like to share with us? What is your experience
Yeah, so,
regarding pachychoroid?
yeah, I've seen some chronic CSR cases.
Yes, yes,
So I have one doubt only.
yes, yes,
So basically, we go for laser to the leaking point, or
yes, yes.
directly we can give anti-VEGF.
No, good question. So, if there is an acute CSR and the patient wants the treatment early, so you can always do an FFA with fundus fluorescein angiography if the leak is extrafoveal. So, it should be more than 500 micron away from the fovea. If it is an extrafoveal or a juxtafoveal leak, you can always do a focal laser. So, with the help of focal laser, what you do is you titrate the laser in the periphery first. So focal laser, we need to just blanch the RP, just visible burn, grade 1 burn. It should not be a grade 2 to 3 burn to avoid any scotomas. So just visible burn, and you can always laser those leaking points. Keep a FFA printout with you. So trace the blood vessel, and along the blood vessel, you do the focal laser to those points. And along with focal laser, if the patient has developed, suppose the chronic CSR, then you supplement it with an anti-VEGF also. Okay, Dr.
Yes,
Zeba,
sir.
I
Thank you.
hope this answers your query.
Yes, sir. Thank you.
Yeah. Any more queries are most welcome. Yeah. Yes. Thank you. Thank you.
thank you, Dr. Jeva. Nice to uh, say you hello. Thank you so much for joining us today. So,
Thank you, sir.
thank you once again. And Dr. Nipun very nicely elaborated the biggest thinking spectrum, and that is getting more common because of the increased so many times thanks so much. Um,
rightly pointed out. So most of the CSR cases in acute phases, if we catch them early, so modifying the risk factors, they can be well treated. The fluid can be resolved. So this modification of the risk factor is very important. So in our competitive world, I mean, the stress is the most important risk factor. So to avoid the stress, and many studies have said that. I just remember that even the yoga and the pranayam, they are very good for relieving the stress and for even for the indirectly benefiting the CSR patients also. So yeah.
Yoga and pranayam is very interesting point. Hold your fight on the board. Battleground. Coming with CSR. Doctor. Even he was usually teaching the subject, but now he was given a job to, address these issues. Any buddy, any user that he has to move, he has to go to the spot in the midnight. He has to travel to all the centers of, that particular coaching across India, like
Right.
52 centers he has to travel in a year. So his job suddenly, they were changing job profile. And when he came to with his CSR, then it was he was very disturbed. And that time, then he met Dr. Nipun, and Dr. Nipun was prescribed Dorzolamide, and then, Nepoconnect, and then you explained about the lifestyle. So his wife told me always, what I learned while talking, always talk to his spouse also. So when I was talking to his spouse, he also doctor. She told me that, he's spending a lot of time, like, late night he's sleeping, he's scrolling, watching the Instagram reels. So he always sleeps till 2 o'clock in the morning. So, and whenever his children use mobile phone, and he is very angry. So his daughter told him one day that, Papa, you are using mobile phone. Remarkable improvement. So we need to really go down to the detail and just spend some time, try to talk to their spouse also, because sometimes they can give messages. They can give you about this knowing us. So that we can reach on the conclusion that which factor will work.
Right.
So thank you so much.
Right.
Any point you want to make?
One point when I was doing my fellowship, so this thing, I used to ask my seniors, sir, we doctors, as sir mentioned, we are in a constant stress like most of the time. So why don't we get CSR? We should also get our OCT done. So they said that there's one protective factor for doctors, that we most of the doctors are myopes. So myopes have a thinner choroid, so we are protected for CSR. That's one point.
Yeah. So this is a very interesting point. And we doctors, we are always, under stress, because sometimes the patients are also putting, transferring our stress, their stress on us. Some patients leave one night, some patients come to the late diagnosis, we wait for video prognosis. Some patients come that if you even after repeated intubation, we are the treatment, the beginning of the journey. So we are always, on the pressure of delivering the best outcome, but sometimes even after explanation, the patients are not able to understand. So what I feel that in such cases, they always write down on their notes, write down in Hindi, explain them in Hindi, and always give them some papers that we go and read about the disease of the user also. So once they will be more independent and correct, they will, be less stress, or they will know what the condition, and then we should always encourage them to be such other patients, so that once they meet the other patient, then they can understand, they can accept that particular disease, they can accept the prognosis. Otherwise, case को पहली बार जब private retinopathy हुआ था तो I still remember one patient was talking to me. He was vendor, so he just told me that the so मैं नहीं आया जी जी पैसे मांगने लगे, जांच कराओ जांच कराओ। बोला बिना जांच के भी कुछ देखोगे या आप जांच करके जाओगे, वैसे करके मुझे बोला क्योंकि मेरा लाइफ और सॉल्व नहीं था।